Hello everyone, today's topic is hereditary spherocytosis. I'll be talking about the pathophysiology, the clinical presentation, laboratory finding, peripheral blood picture, complication and management. And watch the entire video guys, because I'll be talking about what are the other conditions where you see the spherocytes in the peripheral blood. So if you think that my videos are helping you, then please like, share and subscribe. So talking about this disease, this is a hereditary condition. So that's autosomal dominant in 75% of cases and mainly seen in Northern European descent. And as it is an autosomal dominant condition, so there will be a problem in the structural proteins, unlike the autosomal recessive condition where there is a deficiency of enzymes. So looking at this beautiful picture, that we see that this is a RBC membrane. Normally it does have the lipid bilayer, and it is the below the bilayer or the RBC membrane you have the structural proteins. You can see you have a spectrin, which is the head end of the spectrin, and this is the tail end of the spectrin. The spectrin is bound to the band 3 protein in the cell membrane with the help of ancardine and band 4.2, and towards the tail end of the spectrin, along the spectrin and actin, they are binding to the protein glycophorin with the help of band 4.1. So this is the normal structural protein which is responsible for holding the RBC membrane. But what happens in hereditary spherocytosis, as this is a intrinsic defect in the structural proteins of the RBC. So what is happening, that there is a mutation of ancardine, mainly spectrin and also band 3. As a result, they are not able to hold the RBC membrane, and when the RBC are traversing in the splenic circulation, so they get trapped in the splenic circulation and they are engulfed by the splenic macrophage. So when the RBC they lose the membrane, so it becomes smaller in size and they lose the central pallor. So the surface area to volume ratio is decreased, and you can see compared to the normal RBC which has the central pallor, unlike the hereditary spherocytosis where they do not have the central pallor. Okay, so that was the pathophysiology that we see in hereditary spherocytosis. And what is the clinical presentation? We see in a hemolytic anemia is jaundice. Why would you see jaundice? Mainly indirect or unconjugated hyperbilirubinemia. Why? Because when there is a hemolysis, they are releasing this bilirubin. We also discussed the topic of paroxysmal nocturnal hemoglobinuria in the previous video, and if you haven't watched guys, so I'll be putting the link of other videos of my channel in the description box. Okay, and as discussed that why will be there is a splenic enlargement, because this rigid RBC, they are less deformable and they get trapped in the splenic circulation and they are taken out by the splenic macrophage. As a result, there is a splenomegaly. And this is not an autoimmune disease guys, so the Coombs test will be negative, and you will see the mean corpuscular hemoglobin concentration, in short called MCHC, is increased, and normally the MCHC is 31 to 36%. So if you are doing a vignette and you think that it's talking about hereditary spherocytosis, and if the MCHC is more than 36%, then you should think of it may be hereditary spherocytosis. Okay, and what you see in the blood picture, you see that there are a lot of spherocytes in the peripheral blood picture, as there is a membrane damage and there is no central pallor, and you can see some scattered RBC, normal RBC. Why? Because they do have the central pallor here. You also see some occasional polychromatic red cells. Why would you see that? Because when there is a hemolytic anemia, then the bone marrow is trying to compensate and causing erythroid hyperplasia. So you will see the polychromatic red cells in the peripheral blood smear. And what are the two important tests we do for diagnosing this condition? One is the osmotic fragility test. In this test, the RBC are put in a hypotonic solution, So as you can see here, this is the normal RBC, which is biconcave, and when they are put in a hypotonic solution, they have the capacity to enlarge because this is biconcave, and there is less chance of burst. Okay, unlike the rigid RBC in a hereditary spherocytosis, when they are put in a hypotonic solution, then there is no space to enlarge and they burst. Okay, so that's the osmotic fragility test. Another important test we do for this condition is called the EMA test. What is the EMA test? Where the RBC are incubated with this dye, EMA dye, and that will bind covalently to the band 3 and other proteins on the RBC surface. Okay, and the mean fluorescence of EMA stent RBC in patients with hereditary spherocytosis will be low. Why? Because there is a decreased amount of the target proteins. Okay, so these are the two tests we do for the hereditary spherocytosis. And what are the treatment we give is the folic acid supplementation, and of course there is a hemolytic anemia, so we go for blood transfusion. We also go for splenectomy. The reason is that these rigid RBCs, they are trapped in the splenic circulation and taken out by the splenic macrophage. So it's a good idea to take out the spleen, though in the peripheral blood smear we do see the spherocytes even after splenectomy. And why will you go for a cholecystectomy? The reason is because there is a hemolysis, there is more indirect bilirubin, and because more indirect bilirubin will lead to more pigment gallstone, so it's a good idea to take out the gallbladder. And why would you go for a vaccine? Because spleen is responsible for prevention of bacterial infections, mainly the capsulated organism. So it is always a good idea that if you are going for a splenectomy, to vaccinate the patient with polyvalent pneumococcal vaccine. That's always a good idea to give the vaccine in a splenectomized patient. Okay, and another important thing we should know that patients with hereditary spherocytosis, they are prone for parvovirus B19 infection. The reason is that these parvovirus B19, they affect the premature RBC in the bone marrow. As a result, they cause aplastic crisis, where there is a decrease in the premature RBC. Okay, and the differential diagnosis of this condition is autoimmune hemolytic anemia. As I said that what are the other conditions you will see spherocytes in the peripheral blood, and that's autoimmune hemolytic anemia. So we have two different types of autoimmune hemolytic anemia. One is warm and one is the cold. So warm is IgG mediated and cold is IgM mediated. So in a worm where the IgG is sitting on the RBC membrane and they are taken up by the splenic macrophage and then leading to a spherocyte. Okay, so the RBC is becoming a spherocyte now. And how will you differentiate hereditary spherocytosis from autoimmune hemolytic anemia? Because if you are doing a vignette and if you see that there is a spherocytes in the peripheral blood smear, guys, do not go and jump to pick the answer of hereditary spherocytosis, because you will see spherocyte in many other conditions. Okay, so to differentiate between these two important conditions, in an hereditary spherocytosis, as the name says, is an autosomal dominant condition, so the vignette will be talking about family history. Unlike the autoimmune hemolytic anemia, they are immune mediated, so they will not have any family history. And this is cum test will be negative, and this is immunological mediated disease, so the cum test will be positive. And in both conditions you will see the spherocytes in the peripheral blood smear. Okay, so with this guys, I think that this video helped you, and if you think that is specific topic you want to make a video on, so please let me know on the comment section below. And you have a great day, and thanks for watching my video.